Good afternoon and welcome to New Reach's Pathways to Home virtual series. Today we are going to introduce you to our Integrated Care Program, ICP for short. My name is Kellyanne Day and I'm the CEO of New Reach, an agency that inspires independence for all people affected by homelessness and poverty. We do this through a continuum of housing and support using the most innovative, progressive, equitable, and inclusive measures. Today is March 8th, 2022, and it's International Women's Day. March 8th has been the fixed date for International Women's Day since 1914. Today, we celebrate women's achievement and raise awareness against bias. It's the perfect day to highlight the ICP program, a critical intervention program for women who are homeless. The partnership between New Reach and Yale New Haven Health Systems makes it possible for homeless women to be seen, supported, and empowered to take control of their life, their health, and their happiness. Women and families represent the fastest growing groups of the homeless population in the United States. Approximately 34% of the homeless population are families with children. Most homeless families in the United States are led by young single mothers without any family or material resources. Some of the major factors of homelessness among women include domestic violence, of which women are the overwhelming victims, poverty, lack of access to health care and family planning, and the role of women as the primary caregiver of children. These factors contribute to the income and housing implications and inequalities which ensue divorce, decline of the welfare state, and the lack of affordable housing. Additionally, a decline in mental and physical health of women is both a precursor and a consequence of homelessness among the female population. While all homeless people are at increasing risk of poor health outcomes, homeless women especially are less likely to benefit from routine medical or less likely to get the benefit of routine medical assistance, health insurance, cancer screenings, adequate prenatal care, appropriate ambulatory care, and specialty care. Homeless women also face health challenges such as hypertension, arthritis, mental illness, substance use, victimization, and tuberculosis. Homeless women are more at risk for injuries and illness, but receive a disproportionate amount of health services compared to housed women. In fact, 57% of this group do not have regular care provided. Often, women avoid doctors until it's an emergency. Today, you're going to hear about a pilot program that began 3 years ago to address the intersection of homelessness and healthcare for women. You're going to hear from 4 amazing women who implemented the ICP, the Integrated Care Program: Jacinia LeBron, Brooke Lombardo, Beth Klink, and Jordan Nessie. Thank you for joining us today, and I hope that this discussion inspires you to get involved and raises your awareness of the struggles of women who are homeless. Now I will turn it over to Brooke Lombardo from New Reach.
Thank you so much, Kellyanne, for that great introduction. And yes, happy International Women's Day. While we're getting the PowerPoint set up, I wanted to just do a little bit of housekeeping. I think by now everyone really is probably very familiar with Zoom over the last few years, but we just ask that everyone stay on mute while we're presenting. And then if any questions come up as we're sharing the program and experience within the program, we just ask that you put them in the chat so that at the end we have designated time to answer those questions, or if at the end you want to ask your question out loud, you're more than welcome to, and we can answer it then. But in the interim, we're just asking that everyone stay on mute. So without further ado, I'm going to give you a little background on the Integrated Care Program, or as how we refer to it at New Reach as ICP. So Kellyanne had mentioned that this program has been around for the past 3 years, and it is a 5-year grant. So we have about a little less than 2 years left in the grant program. As you can see by this data, the program ideally will be finishing up in September of 2023. And this was a grant that we received from a federal agency called SAMHSA. And SAMHSA stands for Substance Abuse Mental Health Services Administration. So they're under the federal administration. And the goal of the grant was for us to provide services to women in the greater New Haven area who are experiencing homelessness and who have been diagnosed with a co-occurring mental health and substance use disorder, and what we call our sort of high utilizers of the hospital system. So in a little while later, you're going to hear from Beth, who works for Yale New Haven Hospital, and she's been a big part of this partnership and this program. And ideally, the goal was, right, that we're connecting these women who are often showing up at the emergency room and other departments at the hospital, who really are utilizing the hospital maybe for services that they could be getting outside of the hospital from outpatient providers, but that becomes their primary care. And their really biggest issue or the biggest challenge and barrier is them experiencing homelessness at that time. And how can we bridge that gap between utilizing the hospital and accessing housing, and really pushing this idea that maybe some of you have heard around housing is healthcare, which is what sort of our goal of this program is, to show that if people are stably housed, they can in fact increase their mental health, their physical health, and live more sustainable lives because of that ability to have stable housing, right? It's like that foundation that we all need is a place to live. So we have this target population that I shared a little bit with you. And one of the big points that we're trying to hopefully get from the research component of this is, are we in fact, by having this partnership with the hospital, decreasing the women we serve, their utilization of emergency services at the hospital? So one of the really cool and unique parts of this program is that we also have a research component. So we're following very closely the women and providing sort of these 6-month updates on like what's going on in their life, how are they feeling, and then also connecting that with how often have they utilized the hospital, and not necessarily just since enrolling in our program, but after enrolling and becoming housed, what does that utilization look like long-term if they're stably housed? So we do have some really preliminary data that I don't have for you today, but even in the few years that we've been able to start this project and do this research, we really started to see a significant decrease once women are housed in their utilization of the hospital. And they're in fact only really utilizing the hospital for necessary reasons, right? And it's not because of the need for maybe something that they could call their primary care doctor with, because our social workers on the New Reach side are really helping facilitate those relationships and link our women to services, whether that's a mental health therapist, substance use treatment, or seeing a primary care doctor from some medical condition that may have happened due to experiencing homelessness. So that's the goal of the program. That's sort of the overarching kind of process that we take. And as all of our programs, and the goal of New Reach is to make homelessness rare, brief, and one time. And we believe after you guys kind of hear this program, you'll see that this is something that in fact the ICP program is really getting at, with a very vulnerable population that oftentimes is really falling through the cracks with this work. So I have some exciting women with me, as Kellyanne kind of already shared, and some of our staff who are on this program, who aren't on the panel, but are integrate part of this program, is we do have a woman on our program who is designated to helping these women access income benefits, right? Because as we all know, with housing comes the ability to pay for housing. And she has been able to really connect all of our women through a program called SOAR, where she can help them get SSI or SSDI income benefits if they're deemed appropriate, which helps set them up that when they are housed to be able to sustain that housing over time. And then we also have the social workers, which you'll hear from our lead social worker, Jordan, a little later. And then we have our peer specialist. So our peer specialist, Jasenia LeBron, was not able to be here today. However, we were able to interview her prior to starting this panel so that you guys can hear from her. And her experiences as a peer. If you're not in this work, you may not really necessarily know what that means. So hopefully by hearing her, you'll get a better sense of like the role of a peer versus a social worker, and then an experience that she's had with one of our women. So I'd like you guys to take a few minutes and listen to Jasenia's little video. Thank you so much for joining us today, Jasenia. I was hoping you could share with the audience a little bit about your experience as a peer with the Integrated Care Program through sort of the help you've provided for one of the clients in our program.
Yes, first I want to say how happy, how thrilled I am. Being a peer is very meaningful to me. And I would love to talk about specifically of one person that was referred to me through the social worker and in the ICP program, Tiffany. Tiffany was struggling with substance use and addiction and mental health, untreated, and was living in a tent. She was struggling during the cold she battled. During the rainstorms she was living in a tent. So you can imagine how hard that must have been for her. So one day I was trying to connect her to a detox because she was begging to go into a detox. And I saw her from far in the parking lot outside, and I just knew it was her, but I just heard a woman walking. I saw a woman walking and heard a woman crying hysterically. So I run over and I'm like, Tiffany? She comes running to me with her arms open and she's just hugging me and just said, thank God. Do you have a minute to talk? And we were able to sit down. We talked. She was tired. This woman struggled. She's tired. She wanted help and she didn't know how to get this help, but she wanted to get off of the streets. Unfortunately, due to living in the streets, she was hospitalized and became very ill, which impacted her ability to walk. So she had to go into a physical rehab. During this time, when she was discharged, she was able to get housed. However, she was still struggling with living in an apartment and adjusting from living in the streets to having a place to live. Now you have to worry about bills, you have to worry about rent, you have to worry about food and so forth. So we were able to help her, and I was able to work with her and meet her at her place and go over, the things that we do on a regular basis with no issues. And here it is. She's saying, hey, you know what? This is what I want to learn. I want to learn how to cook. I want to learn how to work a computer. And she has been attending NA meetings every day. She has been able to connect now. I was able to teach her how to connect to her Wi-Fi through her phone, and pretty soon she'll be able to connect on the internet with a computer, because thankfully she will be getting a computer pretty soon. So I think that, working with this woman, and that day that I've heard Tiffany crying, I felt that it impacted me, because I too once cried that cry. I know what it felt like to want to get off the streets, these same streets here, and not knowing how. You seem like you're gonna lose your mind, because it's like, I want the help. I want to get off these streets, but what can I do? What do I do? I wish we had a peer when I was struggling in the streets, but thankfully with the social workers that I had, they were able to help me. However, now it's just, I'm glad that I'm connected with these women, because we're able to talk about similar lifestyles and how to overcome these lifestyles, how to change in a positive way, and that it is possible. So I'm like their personal cheerleader. You got this. You can do this. It's possible, because I too once was 90 pounds. And now I'm healthy and I'm living, I'm working as a peer. So, thankfully, a couple of the women that I work with now want to become peers.
Thank you so much, Jasenia. I appreciate you sharing that story with us and your own personal journey a little bit. It's great to have you here.
Thank you.
So, as you can even see from that video, and every time I listen to it, I get reminded of all the incredible work that a peer provides that no really other provider can have if you don't have that lived experience. And Jasenia is such a rare gem in general. I think anyone at New Reach can tell you that, and probably a lot of the women at the hospital as well. Like, she just has this ability to understand and be present. And what she's done for our team has been incredible in the sense that she's been able to help us see a different perspective. So we work as a team, and a lot of the team members might be supporting the same woman for different reasons and for different parts of their goals. And Jasenia always has this ability to kind of challenge us and push us to think about things in a different perspective. And I think there's one point in there that maybe we all take for granted sometimes, but these simple things that maybe is just like, cooking and being comfortable in a home. If you haven't been in a home, as Jasenia said, Tiffany was sleeping in a tent outside for quite a bit of time during pretty cold season, and then to transition to this new life where we've kind of all are like, okay, you just set up your internet, you call the cable bill, you pay your bills, and that can be really overwhelming for someone. And the fact that we have somebody on our team that can walk them through that and also validate how maybe overwhelming and scary that can be is just incredible. So I'm so glad we were able to film her, even though she wasn't able to be here today. But that was a little bit about our work as we do with peer services at New Reach with the ICP program. So now I'm going to transition a little bit so that we can hear from Beth Plink, who is the, and Beth, forgive me if I mess this up, but the clinical director of psychiatric inpatient and psychiatric emergency services at Yale New Haven Hospital's psychiatric hospital. Beth, if anyone could ask, probably me or Jordan, like we're like her fangirls in a lot of ways. We met Beth right when this program started. She was a big part of us writing the grant and creating the policies and procedures and what the program was going to look like from our partnership with the hospital. Beth, believe it or not, if she doesn't look like it, but she's been at Yale for 35 years at the hospital, and in her current role as the clinical director for over 20 years, 22 years, I believe exactly. So she has seen psychiatric services go through several different, facelifts, for lack of a better word, because of all the changes that have happened in the last 35 years with mental health services and understanding that. So it was critical for her to be a part of this program. And we're really happy that she's been able to be here today to talk with all of you about some of the work that is happening on their end. So Beth, I'm hoping you can kind of share with the group a little bit, one, about maybe some of the challenge or barriers that you see day to day when your team is treating women who maybe are experiencing homelessness, and that barrier of hospital care and homeless services, and then maybe kind of sharing with the group a little bit about how New Reach has helped provide or bridge that gap in the relationship that we've had.
Thank you for the invitation to participate today. Before I answer those questions, and I just want to level set a little bit and say I feel like I've had the easy part in all of what's been accomplished by people who work within this program. Essentially, when New Reach approached the hospital to say, we're applying for this grant, we need to partner with our local hospital. Are you willing participants? All I had to do is say yes, and then advertise the program to key individuals within our organization. And that went quite smoothly. It's almost like a rhetorical question. There's a new service of this quality out there. Of course we need it. Of course we'll partner with you. And we hit the ground running and haven't looked back. We're, high volume refers to this program, and could not be more appreciative of New Reach and the dedication to our community in this regard. And then the last thing I'll say, just in honor of International Women's Day, is I'm sure you can feel the energy and the passion, the dedication, and sort of the dynamic personalities of Kellyanne and Brooke, and more to come with Jordan and Yesenia. And it's just that energy is contagious, and it's difficult to not want to actually be a part of what they're doing. So I just felt it important to make those statements before I launch into answering the question. So in terms of barriers that we encounter, as people in the meeting are probably aware, mental illness and substance use are two very tenacious relapsing illnesses. And those facing these co-occurring challenges are frequent visitors to psychiatric emergency services, to the medical side of the emergency department, to our inpatient medical detox units, and often for real health and behavioral health reasons, but sometimes because they just don't know how else to navigate toward meeting basic needs. And that's sort of beyond, right, the mission, the scope, the reach of the hospital to address in any meaningful way. And so, you know, one of the things that I think it's important to underscore is that the analogy I like to use is, in a healthcare environment, we're providing crisis intervention and stabilization. We're setting the leg, so to speak. We have people here long enough to set the leg, but we don't have people here long enough to train them to run the marathon. So we are heavily reliant on our ability to refer to and access services in the community where they do have social workers and clinicians, one sort of mobile on the ground, right, who can meet these individuals where they are, but also who have an expertise beyond the expertise that the hospital has. Our scope is health and behavioral health. It's not navigating the housing service delivery system. And so to be able to refer to an organization that has that expertise feels really good to us in terms of being able to provide something to these individuals who we come to know well, that is meaningful beyond our reach after discharge. So I guess what I'm saying is that the services required by these individuals are beyond the reach of the hospital to provide, and we are very grateful that New Reach can provide them with the tremendous support that they need to engage in and maintain sustained long-term recovery. And when we get to the data sharing, I think you'll see evidence of that. I think the other thing I wanted to say, just in terms of what the collaboration has meant to the hospital, is I don't think we can overstate the intentionality of choosing the term integrated care to reflect that this program is a true partnership between New Reach and the hospital. It's a fairly seamless collaboration at this point. New Reach has badge access to all of the locations in which they need to come to see these patients. They have read-only access to our medical record. They are on site fairly regularly so that we can do more handoffs of new referrals, which is, you know, critical. It's all about developing that rapport and trusting relationship while the patient is still in the hospital. That's going to support the ongoing work after discharge from the hospital. And then they come back, because when these folks do have to utilize health or behavioral health services within the hospital, they continue, the New Reach social workers and peer recovery specialists continue to follow the patients as a source of support as they come in and out of the hospital. So I almost don't even think about us as two separate organizations. I think of us as one collective team that work together on behalf of our mutual clients. And I think that's what SAMHSA was after, is building really in publishing this request for proposals, is to bring social services and healthcare and behavioral health care services together so it's less fragmented for people who are high utilizers of all of those systems, and so that there can be more effective intervention, more effective coordinated intervention. So I'll stop there.
Thank you so much, Beth. I really appreciate you sharing that experience. And you're absolutely right. Like, it is sort of a seamless collaboration. I don't necessarily think of us as two separate entities. The work is so intertwined, and building relationships, as a therapist, that's like the number one thing, right? Like, is building that rapport. And I think the ability to have the positive relationship with the hospital then allows us to kind of build that relationship with the women as well. There is one other thing that you said that is so interesting, talking about it as being sort of this marathon, right? And like you guys are this short-term stop. And, you know, I think that's important for people to understand on the call. And if you're not in this work, a lot of the funding that our agency gets really does have some restrictions on it. And it sort of requires a start and an end. And I think what's been really incredible about the ICP program and the women we serve is that we've been able to have more flexibility, understanding that this isn't like get somebody housed in 6 months and then, you know, good luck. It's very much this sort of long-term marathon that takes time to build sort of these relationships and to help connect these women. A great example of that is we had a woman we worked with at the beginning of the program, and recently she called Jordan to kind of follow up and just check in and say how she was doing. And it was 2 years later, she was still housed and she was starting her own business and she was thriving. And it's like, you know, you don't always hear those stories, especially at the inpatient level, right? That there is this long-term success, and being able to stay connected to these women and have that flexibility, you know, and have that ability to re-enroll women if for some reason they disengage, and be able to do that without sort of sometimes these restrictions that come with, you know, certain grants where we kind of have a certain time and then we have to move on, because this is a marathon. You know, finding housing and being stable in your mental health and your medical conditions doesn't happen overnight. So I think that's really important to remember as well. So I'm really glad you said that. And Beth is, just so you guys know too, I know I already kind of fangirled her, but when we first started this, we joined this community care team, which is sort of a collaboration of different providers in the area and working with individuals who are high utilizers. And I know every time I left that meeting, I was always in awe. Beth has just this wealth of knowledge and expertise and this ability to connect and know how to kind of approach different systems that sometimes are working against us. So it's always a joy. I'm so glad again that you were able to be here, because you are sort of that person that I always look up to, because you have all this incredible knowledge and experience. So thank you again for sharing a little bit about our partnership.
Well, thank you, Brooke. I'm happy to be one piece of the puzzle. It definitely takes the village, though. So
yes,
I've learned a lot from New Reach about housing too.
Yes,
It's been very beneficial to us in serving patients when they're in the hospital. So thank you.
Yeah, of course. So I want to get back to the PowerPoint slide, if we can, as I introduce our lead social worker of the Integrated Care Program, Jordan, who has been a part of the program since its inception 3 years ago. And Jordan, I'm hoping you can share with the group maybe some of the evidence-based practices that you have found in the work that you've done with the women directly that have been successful. When we talk about it, right, like what are best practices and what does that mean? And I think there have been a few in particular that you have found to be really beneficial in this work. So I was hoping you can share with the group some of that experience that you've had.
Sure, thanks, Brooke. First, I'd like to keep the momentum going with International Women's Day. Points out I work alongside an incredible team of women who Brooke has mentioned, but they really go above and beyond for the clients we serve. Our peer Desenia, who you heard from, our source specialist Jennifer, who helps connect our women to benefits, and our second social worker Tina, and all under the guidance and support of Brooke. So shout out to my team. We do incredible work in collaboration with Yale. So to answer your question though, there are really two evidence-based practices that I believe that we use that I believe has led to a lot of success and successful outcomes over the years. The first is harm reduction, and the second is a housing first approach. So I'd like to start with harm reduction and give some examples of how we use harm reduction with our clients. It might be helpful to first define what harm reduction is, and the best definition I've heard that I believe is pretty widely used amongst providers in the field is meeting a client where they're at. And so in ICP, when we think about meeting a client where they're at as a program, we usually have to start by assessing their current circumstances. So that might be where they're living, their psychiatric diagnoses, whether they're being treated, if they're actively using substances, and maybe what providers they're connected to, and so on. So harm reduction kind of allows us to work towards realistic goals. And when we help clients identify their goals, that's what the framework we're trying to work within. So for example, if a client says that, their ultimate goal is sobriety, it was kind of unrealistic to write down, stop using substances. It's not super helpful for them in terms of how they can make achievable goals. So when we think about harm reduction, and from a harm reductionist viewpoint, the goal might look something like decrease the amount of substances one's using a day. If someone says they start drinking alcohol at 9 a.m., can we talk about how we hold off until later in the day if they feel like they need to use? And we find those are really helpful tools, and it makes the goals achievable. And so there's something that can evolve over time. It also really helps the clients to feel empowered, so that they continue to be successful in our program. So another way we use harm reduction in, another goal that clients often set for themselves is to connect or maintain a connection with medicated assisted treatment. So there's a lot of collaboration with the MAT programs locally. So if you've heard of methadone or Suboxone or Vivitrol, those are all examples of medicated assisted treatments or MAT programs. And they're also great examples of harm reduction. And they really are crucial resources for the clients that are enrolled in ICP. And we also collaborate with a number of other community providers who use the harm reduction approach. Cornell Scott Hill Health and Connecticut Mental Health Center, or CMHC, are both great examples. They both have street medicine and or street psychiatry teams that will go out and meet the client where they're at. They'll meet them on the street, they'll provide treatment and care. And they've been especially helpful during the height of COVID. They were always, first responders and really providing a lot of that care. And so we've been collaborating a lot with them over the years. Yale also has a community healthcare van, which is a mobile van that goes into the most vulnerable communities in New Haven, and they serve people experiencing homelessness. So they might be in the New Haven Green one day, or they will into Fairhaven. They also provide similar services to Cornell and CMHC with medical and psychiatric care. And they're very, very big proponents of harm reduction. They'll host needle exchanges for individuals using substances by injection, so they can bring their used needles and have new ones to decrease the risk of infection. They also provide fentanyl strips, which are little strips that can help detect for fentanyl and drugs, which can really decrease the risk of someone overdosing on fentanyl. So it's a huge resource. And those are all really good examples of harm reduction and the resources that we often encourage our clients to utilize. And then I just want to mention one other harm reduction collaboration that we have. Another organization that utilizes harm reduction is SWAN, which is Sex Workers Alliance Network. So a lot of our women are engaging in survival sex work, and SWAN has been an incredible resource for them. They have support groups. They also often have harm reduction kits, which might include things for safer sex and safer drug use, condoms and Narcan. And if anyone doesn't know, Narcan is a medicine used for its intended use is to reverse an opioid overdose. It comes in a nasal spray. But when I think about what Jasenia shared in her story about Tiffany and how it really shows how harm reduction helped her in her success. We did a lot of work to set achievable goals for her and connected her to a lot of the resources that I mentioned. And of course, Jasenia's continued support as a peer was crucial in her success. And ultimately our client was empowered to continue on her path to recovery. So I'd like to move on to the housing first approach, which is kind of what it sounds like. ICP's overall or overarching goal is really to find stable housing or stable environment for all of our clients. And the housing first approach really believes that individuals who are housed can then sort of work on their personal goals. So when I think about Tiffany, I remember meeting with her, and she often described herself as feeling stuck. And when she sort of explained further what she meant by that, Tiffany was literally living on the street. She was in an encampment, living in a tent for about a year. And she wanted to go into treatment, as Jasenia was saying, but she felt stuck because she would go into treatment and maybe make progress, but then she'd end up back on the street. And she was kind of in this vicious cycle of not being in an environment that was conducive to her working towards her recovery goals and maintaining sobriety, or even, psychiatric medication management. So what our team really did, and what we usually do for our clients, is we identify immediately what resources are available within the community, which often goes through the coordinated access network, sort of the gatekeepers of these housing resources. And we provide documentation that proves she's been experiencing homelessness and she has these barriers and really in need of housing. So that sort of leads to her being put on a prioritized housing list and having the opportunity to match to permanent supportive housing, which is where she is now. So she has her own space. And as Jasenia said, she then, was able to go into physical rehab. She also had psychiatric inpatient treatment at the time too, but she knew that she could return back to a stable environment, which was a huge help for her. Tiffany was also engaged in our SOAR program with Jen, who assisted with her connecting to Social Security benefits. So she now has income, which opens up the door for her to kind of have more opportunity if she were to choose to move down the road. So I really just believe that Tiffany is a great example of someone who utilized all of our resources in ICP, which helped with her success, but she also really illustrates, the work we do with harm reduction and the housing first approach. So that's what I wanted to share. Thanks, Brooke.
Thanks so much, Jordan. And before we get into some opening it up to the group, if anyone has questions, I think one thing you said, Jordan, made me think about how ICP really becomes this home base for these women. So Jordan shared a lot about other sort of resources, especially when she was talking about harm reduction, right? These different organizations in the community that we're connected to. And I think what's really incredible is that ICP has this ability where we become their home base, right? We have these internal resources, whether it's access to helping someone obtain income, or, through Jasenia peer recovery support or our social workers. But really what we also do is help identify these other resources in the community that we can connect these women to for this long-term support. And we become constantly that home base of knowing all those resources, and really, with depending on what the individual's goals are, being able to then say, like, okay, we have this resource, and really building these relationships, not just with the hospital, but these other providers in the community, right? Because our goal, like I said at the beginning, is to help them decrease utilizing the hospital and only really using it if they need to, that it's appropriate, but rather using all these outside resources. And ICP really does become that home base. We're that constant sort of provider that they can come back to and utilize in order to connect to these other agencies, throughout the community, not just for housing, but for harm reduction. So thank you for that reminder, Jordan. I think it was great that you were able to kind of walk us through the experience of Tiffany, who we heard about from Jasenia as well. So that being said, I am going to open it up to see if anyone has questions. You can certainly put a question in the chat, or if someone wants to, there's the option, I think, reactions, to raise your hand, or if you want to just take yourself off mute, we can certainly hopefully be able to answer some questions. I did put up our email addresses and contact if there's any one of us that you want to follow up with, or have any follow-up questions. I see there's a typo, so my bad, Jasenia, that's ORG, so org, it's newreach.org, but that is her name in case you wanted to connect with her. So it looks like we have one question in the chat that is for Beth. And Beth, I'm wondering if you can answer this question. So someone's asking a little bit about, what does the referral process to ICP look like for the hospital?
Sure. You and I and others work together to make the referral process as sort of least labor intensive and time consuming as possible for referring social workers and clinicians in a very busy hospital environment, especially an emergency department setting. One of the barriers to referrals is if you make the process too cumbersome. And so we actually have a very brief referral form that we built into our electronic medical record, and the clinicians can go in and submit the required information, which is pretty basic. New Reach does not require a lot of information for them to quickly orient to the patient's needs. And then, part of why that is because we have given the read-only access. So whatever other information needs rounding out, the New Reach social workers and clinicians can garner right from the medical record. I will go back and say, in terms of admission criteria, we do have key culture carriers, sort of champions of this program in each of the locations throughout the hospital that these individuals frequent. And so they, when they're doing their initial interview and assessment with the patient, they constantly have the criteria for referral to this program in the back of their mind. And as soon as they identify someone meets the criteria, then it's almost an auto referral at this point. I mean, they do have to engage the patient to agree to the referral, but we have a very high hit rate in that regard. Again, for the most part, people are very receptive to at least trying once any offer of help that's provided. So once New Reach gets the referral, again, we can't always hold people in psychiatric emergency services until that warm handoff can be done. And certainly there was a barrier there in terms of visitor restrictions during the pandemic. However, I will also say another shout out to New Reach. They were one of our first, I think probably our first community provider who decided to go mobile in the community again, which was great. Because a lot of these folks do rely on meeting them where they're at, not just in terms of the disease process and psychologically, but even physically. They can't always get to where services are provided. So this program brings the services to them. But anyway, we try to do that warm handoff. If that doesn't work, then we communicate and collaborate pretty carefully around how we have learned it might be easiest for New Reach to connect with the patient post-discharge. And then the communication and collaboration is just very fluid through that whole process, very painless. I mean, we feel like we have just very easy and timely access.
Thank you, Beth. So there's two other questions in here that I think I can try to answer, and Jordan, jump in if you'd like. One that I'm going to answer first, even though it was in here second, because it is very quick, was asked, what is the average number of referrals per month since the program started? So on average, we were seeing probably, I would say about 5 women or so are getting referred to our program, which I know may not sound like a lot. However, because of the intensity of the services we provide, it allows us the opportunity really to work very closely with these women and follow them through the process of engaging and connecting them and finding housing for them. It did slow down, like as a lot of things did with COVID. There was a period of time at the beginning of COVID where the hospital, for obvious reasons, wasn't necessarily allowing people to come into the hospital unless they really needed to for admission. So there was, and people were scared. So there wasn't as many people maybe going to the hospital for these resources. But since obviously COVID's been around for quite some time now, that's changed. And I would say on average, we're getting around 5 or so women that we are able to connect with each month. The question before that was asking about what happens when funding runs out. So that's a great question, Mary. Something we're really focused on right now, as I mentioned at the beginning, we're now in year 4 of a 5-year grant that SAMHSA has provided us. And we're really sort of looking at sustainability of this program. And what does that mean? Because it has been such a benefit to the community, to the hospital, to the women we serve, and really starting to think about how can we continue to serve this population beyond the grant funded program. So we are in the process of, hopefully trying to help utilize the data that we've received so far and to kind of share how this program really is different than sort of the traditional programs that you see happening in the housing world, if people are familiar with that. So we are in the process now of really hoping to keep this program going beyond the funding of it in 5 years. It's just a matter of being able to, connect with resources that can see that and can invest in this program more long-term. So that is our hope, and that is our main priority right now, because we have seen through the research and through the qualitative data of working with the women how beneficial this is, not just to them, but even just to the hospital and to the providers having that home base through the ICP program. And I am wanting to be conscious of time. I know we have 1 minute left, and Kellyanne, I know you probably want to just kind of wrap us up. So this last question about what happens after discharge, we're hoping at that point, like Jasenia's kind of said, is the goal of the program is to hand them off to other providers that can provide long-term care. So the hope is that they stay connected. Like I gave that example of a woman reaching out and keeping us posted, and we follow the women past discharge to get information, make sure they're still connected. But that's our hope, right? That this is a temporary support that then becomes long-term through these other providers in the community that provide long-term care. So at that, I'm going to hand it back over to Kellyanne to just wrap us up.
Thank you, Brooke, and thank you, Beth and Jordan and Jasenia. Many thanks to the New Reach team that helped to put together this event today. And again, thank you all for being here. We thank the New Reach team. We thank Yale New Haven Health System, their team, for working to make change for homeless women. I'd also like to thank our corporate sponsor, Nutmeg Consulting, who's an IT and managed services company who helped to transform the collection of data for over hundreds of nonprofits across the state of Connecticut. And just to let you know, if you are new to New Reach, please feel free to contact us for information about our vision to make homelessness rare, brief, and non-recurring. I also invite you to attend our event, Stand Up Against Homelessness, featuring Jim Brewer, a sit-down dinner, and a live auction with Eric Hummel. The event is on April 9th at the Omni Hotel in New Haven, and you can find out more about that event on our website, newreach.org. Thank you.